Hey, easily my favorite word in clinical medicine is glomerulonephritity. It just rolls off the tongue. In this video, we'll talk about some basic introductory vocabulary for glomerular disease, as well as anchor ourselves conceptually in important clinical features of glomerular disease and crystallize some clinical phenotypes. Let's do it.
Kidney Bass Tommy.
All right, we're going to anchor our conversation of glomerular disease in two clinical features. The first is proteinuria, and the second is hematuria. Now, these are such important clinical features that additional videos will be dedicated to each separately. We can arrange them essentially on an x-axis. So you can call to mind like a thin little rectangle that's like the shape of a hot dog, and you slice it on a diagonal to make two triangles, such that on one end we have lots of proteinuria, and on the other hand we have isolated hematuria. All right, so with that in mind, let's move on and talk a little bit about crystallizing those two clinical phenotypes. The first of the clinical phenotypes is nephrotic syndrome. The KDIGO guidelines basically say that there are three attributes to nephrotic syndrome that you need in order to call a patient as having nephrotic syndrome. So the most important is going to be nephrotic range proteinuria. And that's going to be 3 grams of protein in 24 hours. The second feature is going to be hypoalbuminemia. And the third feature is going to be clinical edema. And that's it. Now, you may be saying to yourself, I thought that I learned in medical school other adjectives or other features of nephrotic syndrome. CBAS, what about being in a prothrombotic state? Or what about being immunosuppressed? Sure, these are all additional features of nephrotic syndrome, but I want to put those on a second tier, or the, so to speak, second shelf. We really need to focus on those core 3 attributes and have those crystallized so that we can contrast it to the next clinical syndrome, which is nephritic. Okay, nephritic syndrome, I like to think of as having essentially 2.5 features. So in order to label someone as having nephritic syndrome, the most important thing classically is for that patient to have glomerular hematuria. If we look at all hematuria under one big umbrella, a subset of that hematuria will localize to the glomerulus, and we know that it localizes to the glomerulus with certain features that we are going to be able to see under urine sediment in order to label it glomerular. More on that later in a separate video. The second feature that we need to have for nephritic syndrome is going to be some proteinuria. Now, there are some glomerular diseases that present with essentially isolated hematuria, but for the most part, there will be some amount of proteinuria around. And finally, the 0.5 feature. Many cases of glomerulonephritis, are for nephritic syndrome specifically, are going to have AKI. And so that's the 0.5 in order to round out our 2.5 features. All right, so quick and dirty recap. We're going to set on one end of the spectrum nephrotic syndrome and say those patients have nephrotic range proteinuria, hypoalbuminemia, and clinically will have edema. And then on the other end of the spectrum, we're going to set up nephritic syndrome, and we're going to say those patients have to have glomerular hematuria, and they are often going to have AKI, and they'll probably have some amount of proteinuria. Those are our two clinical phenotypes. Now, what do they share in common? Typically the presence of some proteinuria. What sets them apart? Well, the main classical thing that's going to set them apart is the presence or absence of hematuria in the consideration of nephritic syndrome, the amount of proteinuria in the consideration of nephrotic syndrome, and typically, nephrotic syndrome will not present with AKI, whereas typically nephritic syndrome does present with AKI. And those are our two clinical phenotypes. Okay, next up, let's spend just a little bit of time talking about additional vocab terms that you may hear. Rapid progressive glomerular nephritis is essentially superimposing a very specific tempo on top of nephritic syndrome. So it's saying, hey, this nephritic syndrome has presented in a matter of days to weeks. Its pathologic correlate, the actual histopathology, is crescentic glomerular nephritis. All right? And so those two things are intertwined and go hand in hand, rpgn and crescents. Crescents? All right. And I think that we'll get to in a second what it means if you are thinking of a patient having rpgn. So those are some vocab terms that we might talk about. All right, last but not least, we want to talk about one important clinical treatment implication of labeling someone with nephrotic versus nephritic syndrome. Certainly there are overlap syndromes in which the patient gets sort of stuck in the dead middle. But if you feel comfortable that the patient exists at one end of these spectrums, then you're going to want to take into consideration diagnostics versus treatment. So for nephrotic syndrome, classical pure nephrotic syndrome, you're going to have time to think, to deliberate, to gather additional diagnostic data before you commit yourself to a particular treatment course. And this is contrasted with pure nephritic syndrome. So nephritic syndrome, I want you to sear this in your brain, means inflammation. And if there is active inflammation going on in the kidney, and it is happening over the course of days to a few weeks, you are pushed many times to treat empirically up front while you are simultaneously getting diagnostic information because you are so concerned about preserving parenchyma. Dope. Here's the super quick recap. We anchored our discussion in glomerular basics by saying that we should visualize a spectrum where proteinuria exists on one end and hematuria exists on the other. We talked about the clinical features of the main two phenotypes, nephrotic and nephritic syndrome. We quickly went over a few other vocabulary terms that are bantered about on the wards and specifically highlighted rapidly progressive glomerular nephritis and its histopathologic correlate, crescents. And last but not least, we talked about the important treatment implication of nephrotic syndrome oftentimes giving you some time to get the diagnosis before you commit to treatment, whereas for nephritic syndrome, you often have to simultaneously empirically treat while you're gathering diagnostic data. Sweet! If you managed to make it this far in the video, then you are one of the few lucky viewers who gets to see my ridiculous hair without this silly pink Tokyo cap. I really appreciate you taking a look at my video. If you learned something, please like and subscribe, and check out maybe this guy up here or this one over here. Thanks again.